And greetings, everyone. We're so glad that you've joined us for today's PCRC webinar. And we are so delighted to have with us today Dr. Ronit Elk, who is professor of the Department of Medicine, the Division of Geriatrics, Gerontology, and Palliative Care at the University of Alabama, Birmingham. She's also the Associate Director of the Center for Palliative and Supportive Care and of the Southeast Institute for Innovation in Palliative Care. Her research focuses on partnering with underserved communities to develop culturally concordant palliative care interventions based on the community's cultural values and preferences at the end of life, and then in training clinicians to provide that culturally concordant care. Dr. Elk has published extensively, but she is most proud of her work as the guest editor of the special issue in the Journal of Palliative Medicine focusing on palliative care and end-of-life care for African Americans. If you're interested, her editorial is titled, "The First Step is Recognizing, Acknowledging, and Respecting the Inequity, Disrespect, and Disregard our African American patients have experienced." You're going to hear more about this today. So welcome, Dr. Elk, and we're so glad to hear from you today.
How lovely to be here. Thank you, everybody, for the invitation and for the opportunity to talk to you about what I believe is a very important topic. I'm going to talk to you about three things, and I wanted to start by talking about the impact of culture. And you'll see why I want to talk about culture and how it very, very much impacts the care of the seriously ill patient and the family. There's certain specific aspects that are different in our African American communities that we really need to pay attention to in addition to cultural values. And I will be addressing that in the second part of our talk. And in the third part, I'm going to talk to you about how we can develop culturally based healthcare programs based on the cultural values and realities, but it's the community that develops it for the community. So let's start by culture. Why is culture so important? First, look at this slide. You see how on the top you just see 10%? Think about a culture that you're not terribly familiar with, but you think you know a little bit about it. So you know, oh, I know their food, I love their food, I go to all their festivals, love the dancing and the music, and I've even bought an art picture, you know, those kinds of things. What we don't know about a particular culture, and this is all of us, unless we delve very, very deeply into it, are all the other aspects. For example, what does it mean to be courteous? What does it mean to be polite? What are the attitudes towards elders? Very different. Anybody who's been to a Native American powwow can see how elders are treated with such respect compared to in our more, I don't know, American society. What is the concept of time? What is the concept of self, etc.? And then how people communicate. So you can see how all these aspects are very, very critical to healthcare. Now think about what culture you belong to. It could be anything. Everybody knows what culture they belong to, everybody. It could be one thing, it could be more than one. But when you are ill, when each of us is ill, we perceive illness, suffering, dying, death, all through our own cultural lens. And this lens could be very, very different depending on the culture. In fact, it really is. So let me tell you about 4 ways that culture is so impactful in palliative care. So the first thing it influences is the preferences for care, the process of care, like how much I want to know about my prognosis, to what extent is my family involved in the decisions, what kind of medical intervention I want, what kind of palliative care intervention I want, what are the goals of treatment? All these kinds of things that don't even talk to me about advanced care planning. I will tell you a little bit more about a study that we're working on in that, because that's a whole other area. The culture also influences how people talk, and what people talk about. For example, the time till death, when we say, the physicians or nurse practitioners say, really, I think that there's going to be X amount of time before your loved one passes. It is not appropriate in the Southern African American culture. Why? Because it is God who decides, not the physician who decides. And so how would you know how long it is? Plus, a miracle could always happen. I'm only touching on this superficially now. I want to give you an overview first. It also influences the meaning of suffering. For example, one of the suffering and the way we express grief, it varies by culture. I believe I've been to so many African American funerals. I have been to many Jewish funerals. I have been to other funerals, and I can see how it varies from different cultures. Now, this picture here below is so beautiful, and it depicts a concept of group connectedness, not the individual as is stressed in America or in our westernized society, but the group. And the concept is called Ubuntu, and that's in sub-Saharan Africa. But it is also very common in African Americans in the US. And finally, this whole aspect of decision-making, which is so critical, particularly in our field, in palliative care, it really varies whether a culture is an individual culture, like I've spoken to the patient and the patient knows, or whether it's a communal culture, which is you've got to have the family there. You've got to maybe even have the pastor there. They are the decision makers, not the individual patient. And as I said, God is the ultimate authority in many cultures, not only African American, whereas in Western societies, we're more in terms of whatever the physician says. And then how wishes for end-of-life care, that is also impacted very much by culture. So now you can see how critical culture is in palliative care. And there's an article here that we have written that sort of explains all these four concepts in case you want to know more detail. Here's the strange thing. End-of-life care values in the US are historically rooted in values that represent the cultural and religious values of the white middle class. So if you're white, middle class Christian, it works extremely well. If you're not, these are values that not only are not applicable to other groups, but a lack of sensitivity and a lack of respect for these may significantly, and not only may, but actually do significantly compromise care for minority patients who are seriously ill or dying. And I know that's difficult, a concept to understand or grasp. It's not understand is not difficult, but to grasp, because every one of you is doing your best for your patients. And the realization that you may significantly compromise care because you don't understand the culture may be hard to understand and hard to sort of feel. But let me tell you how this can be remedied. First of all, we found that there were no culturally concordant end-of-life programs to address the specific values of a particular cultural group. And we knew this could be created, so we created it. And so what I'd like to do before I jump into talking about that, the creation of culture, I want to come back, take a step back, and to talk about something that's in addition to culture, which is something that happens particularly in the African American community, that we in the United States must address. As Dr. Ritchie has explained, to me, this is the most important concept, that we understand and we recognize it and we acknowledge what has gone on with our African American patients. Even if you've never been racist, even if you've never done anything, you yourself is disrespectful, this has happened. And let me tell you how. Slavery is so entrenched, it's felt in the DNA. As the grandchild of somebody who is a Holocaust survivor, I can tell you that studies have been done to show that it's in our memories through the generations. And what I love is this quote: "What happened on that auction block centuries ago is still unfinished business for African American women and men today." Remember that. It is unfinished business. And if we thought that wasn't enough, what there also is racism. There's individual racism and systemic racism that affects the life of each and every member of an African American community member. If you know anybody who's African American, could be your friend, your loved one, it could be your colleague, it could be your patients. Every single one of them have been subject to racism in the most appalling way. Every single one. And so that is something that is a trauma that is carried in each one of our patients, African American patients. We have to remember that. The other thing that's absolutely disturbing is that not only is there Tuskegee, which everybody talks about, but there have been medical experiments on Black Americans through the colonial times to the present. And when people say to me, "Oh yeah, Tuskegee," and we've apologized for that, no, it is not just Tuskegee. And what's happened is there's a beautiful new paper, which, now that with the awakening of America to the reality of systemic racism, which many of us have been shouting about for so long, this issue of medical racism, have you ever seen that concept before? No. Medical racism and violence in the United States is occurring and continues to occur. And this is in the Lancet, which is one of the top journals just this year. So let's look at some of the things. Well, pain management, something that we're very familiar with. It's not assessed as well in Black patients, and the pain isn't managed as well. So there you have people suffering with pain and complications of pain unnecessarily. And what about goals of care? They're often less discussed by physicians with African American patients than with whites. It is less recorded by physicians or nurses in the chart. And even when African Americans have written the goals of care and they have them in the chart, often they're not followed or respected. Imagine if this was your family. And here are the references to let you know I am not speaking just out of my emotion. I am telling you what is a reality for our African American patients. And this has come to a head in COVID. Look how many people in the African American patients, people in the community have had 2.6% higher. These rates vary depending on the time. And we try to get this as late as possible. 2.6 times higher rate, 4.7 times higher hospitalizations, and at least double the rates of death. I've seen figures that are much higher. Here is another graph that shows you very clearly that with African American as well as indigenous groups, look at the high death rates from COVID. In short, this is from till October 13th. We know it's 2 or more times as high, the mortality. And that means in less than 1,000 African Americans have died. One in less than 100,000 have died. Each one of these is a loved one of somebody, each one. And so a colleague of mine, whom I respect so greatly, has written a superb paper, and it's called syndemics. Now, syndemics is a term I had never heard of before. It is actually a collusion of epidemics. So we know the coronavirus is one epidemic, or even worse, and systemic racism is the other. And what happens is the racial inequities in COVID, they didn't occur randomly or by chance. They are actually actively produced through anti-Black systemic racism. And it wasn't just this paper, there have been many others, but this is the National Institute of Healthcare Management has come out this month with a paper showing that systemic racism is a public health crisis. And I can give you more of the references if anybody wants them. But they talk about what are the leading inequities. It is not, I mean, I get so angry when people say, well, there's more diabetes or whatever it is. The wealth, the housing insecurity, the food insecurity, the mass incarceration, the lower level of education, all of this is a result of systemic racism. It is not a chance. And in this slide, it shows you how it becomes, how this chronic stress impacts our health. All this chronic stress impacts the health of our African-American patients. So now that I've talked about it, my blood pressure goes up every time I talk about it, even though I'm aware of it. One of the things that we want to focus on is what is it that we can do to change it. We do need to address provider bias, and we are working on it, and I'll tell you a method, but we're also talking about reaching out to communities and engaging with communities. So let me tell you about that part. Before I do, I just want to say that our deans, the dean of our medical schools suggest this time of COVID is such a challenging and troubling moment. Let's identify our opportunities to make an impact and build something better. And I ask each one of you to make that commitment today. There's so much we need to do. There is so much we need to address. We need to address personal racism, we need to confront systemic racism, and we need to confront and deal with disparities in healthcare that we've all known that have been there for a while. We can't reduce disparities in healthcare, we must achieve health equity. So what my calling is, each one of us has our own calling. I partner with communities, underserved communities, to find out what their cultural values and partnerships are. And that in beautiful partnerships with these communities, I build programs that are based on that. Not enough to build these programs, we have to train our clinicians so that they understand the patients better, and then they, as a result, are able to respect the values, which means patients and their families are heard and understood, and they get care that is concordant with their own values and wishes. And this is not happening. I'm not saying it's not happening in one case or in another case, but in general, it is not. And imagine what we can achieve if it is. Both of these studies, as I say, has been developed in partnership. Both were developed in South Carolina, although we're now doing one in Birmingham. You will see here that in the first study, there are both whites and African Americans. When I approached the hospital and I wanted to develop this program for African Americans, I was not permitted unless we developed it for the white community too. And since this was a rural community and very much underserved, we thought that, okay, we'll do it for both whites and African Americans in this rural community. That had no palliative care whatsoever. So the first study, what did we want to do? We want to develop a consult program, not a full palliative care program, because we don't have the staff. There weren't even palliative care docs there. And so what we wanted to do was to do a consult and that respected the values of African American, white, rural, Southern elders. Let me tell you about this incredible concept. It's called community-based participatory research. It is a concept from public health that can easily be used in our world. What you do is you partner with the community. Whether you have 5 MD degrees, 3 PhD degrees, a whole bunch of numbers, letters after your name, irrelevant. It is the community that has the power. It is the community that have the answers. It is the community that owns the process. Therefore, it is a social justice method. I've simplified this whole concept. And one day I'll have a whole course on this if anybody wants it. But this method has been proven for many years to reduce health disparities. So why are we not all using this method? I have no clue. I am here to mentor anybody who wants to learn about this method, which sounds simple. It's a little bit more complicated than it sounds. But if we truly want to make a difference, this is the way to do it. The first step is you appoint an advisory group. It's called a community advisory group. They are from the same group that you are serving. So if you're serving African Americans, they're African Americans. If they're white and African Americans, they're white and African Americans. They have experience with the issue you're addressing. So it could be death, it could be serious illness, it could be caregivers of loved ones who have a serious illness. You could have patients who have a serious illness, although I have found that those with such serious illness sometimes are not able to participate. You must have some leaders from the community who are very well respected. And you always have to have somebody from the hospital or hospice or wherever you're working. Why? So that you can develop something that's feasible, not something that the hospital will have an absolute, fit about. And regular people from the community. Here's the thing, you get involved with the community, you tell them about the study before you start the study, during each step, and after. Remember, the study belongs to them, the process belongs to them, and therefore it is their right to hear about everything that you have found out and what you are going to be doing, or what the community is going to be doing. And, for somebody like myself who, had a very senior position in another organization before and was able to run big meetings, etc., it's irrelevant. As I said, it is the community's answers. So I had to keep quiet, ask the questions and listen. Ask and listen. Because the community knows what they want. The community knows what's going on. The community knows what the answers are. And if you have to change what you wanted to do or what you wrote for the research study, too bad, change it. Because the community is the guide. And remember that whenever you're going to be partnering with communities, it takes time and genuine respect to build and establish trust. The second concept that we did is evidence-based palliative care. So in the top right-hand corner, here's our palliative care physician. Well, as I said, when I started, there were no palliative care physicians at all in South Carolina. Thank God this changed. But I partnered with Josh Hauser, Dr. Hauser, who got a South Carolina license and participated in the calls, in the meetings with the community every single month. And then 2 times he actually came down to meet with the community, and he guided us to make sure that we were following exactly the palliative care methods. Don't worry about the slide, just look at the right-hand side. There are 3 phases to the study. The first phase, of course, is to have the advisory group, and then we have focus groups. The second phase, developing the program. The third phase, testing it in a hospital to see how feasible it is, or if it's not feasible, what do you need to do to fix it? Well, the first thing our advisory group said, no, you're going to have focus groups, you're going to have separate for African Americans and whites. I said, isn't that racist? No. If you want our people, meaning African Americans, to talk and share with you, they have to feel safe, and they cannot feel safe in a mixed group. So this is a photograph taken from the internet. It is not our our focus group members. We didn't ask permission, so we can't post it. But just to show that we changed our study for that. Then the way you do this is that you tape all these sessions, and then you do an analysis of what themes come up. And some of the themes, zillions of themes came up. I'll show you the article where you can read more about it. But some of the themes that came up was everybody had experienced, not everybody, but almost all, very poor physician communication, just awful things that were said by physicians to patients. None of them were, of course, palliative care physicians. And this results in people having even less trust in physicians than for other reasons. The whole issue of how to share prognosis is key for both groups and very different for whites and African Americans, etc. When we went to phase 2, the building of the program, I just have this slide here to illustrate how the palliative care team partnered with the community members and the hospital staff on an equal level. We didn't make recommendations, the community did. The hospital staff would just talk about what's feasible and what's not, but the recommendations came from the community. And what we did is discuss each theme. I hate it when things look so complicated, but basically we told them each theme, and then the community made recommendations. If it was only for the African Americans, then the African Americans make recommendations. If it was for the whites, and then if it was for both members of the group made the recommendations. You know that it took 2 years, 2 full years of monthly meetings to do this, and nobody missed a meeting except the lady in the right-hand side, who was a widow, who at church met another widower whose wife had died of the same illness, so they had a similar trajectory, and they decided to get married. And she was very disappointed at having to miss a meeting. That's how seriously and how committed the community were to these monthly meetings. I just wanted to show that the role of religion and church in the rural South is very different. There was a protocol that was developed, and I'll show you the paper. I didn't want to go into it now, but there's things about how you give prognosis to African Americans and how you give it to whites, very different, very different. And I will tell you at the end of this talk about a conference that we will be having in November in a few weeks that you could learn more about if you truly want to care for your African American patients in an appropriate way. And then the third phase was, to see if it would work. Again, the African American Community Advisory Board said, let us meet the patients first. Let us break the distrust down. Let us let the community members know we developed this program. The doctors are going to be listening to us, and we tell them how to talk to us and what to say and how to respect us. And then the white group thought that would be very helpful for them too. And so that was done. It's a small sample size, but you can see that the family members were very, very satisfied with the care that they received. The patients were far too ill at this stage to comment. So in short, we have developed together a palliative care program. This was taken from our closing ceremony where everybody came. It was everybody from the community. They had invited their family members, and the community has ownership of it. And it's the first such program in the US. Frankly, I haven't seen anything in other countries either, but I didn't want to be sort of think that we did something that was internationally a first. What's happening now is that this study, the first phase of the study, is being replicated in Ghana, and the paper will come out soon. It's being replicated in Puerto Rico. I simply mentored those physicians by Zoom, Skype, whatever, over the years. It'll soon be done in Nigeria. And it'll also be done with other groups in the US. There's a physician who's going to be doing it with Hindu patients. And this is the paper that summarizes everything very clearly. It's a culturally based consult, and it's a program by the community and for the community. So now we had to see, oh, is it effective? You know, you could say, well, yeah, you haven't done a randomized control trial. You've shown that it's feasible, but let's see if it's effective. So we're doing a randomized control trial. This is with Dr. Bakitas and myself. And what we're doing is 3 rural hospitals, Mississippi, Alabama, Carolina. And each of them, as you see, has a community advisory group. If this is found to be, this particular method is found to be effective in reducing suffering, increasing quality of life, and hopefully helping patients feel like their culture was respected. Can you imagine? This would be a whole new evidence-based clinical guidelines. And what I love about research is that you can create such new evidence-based guidelines. What I don't like is it takes forever. So we're in year 3 of the study. But guess what? How did the physicians get trained? We brought them down to the community and we did a cultural immersion, and it was the community that taught them. It was the community that explained the cultural aspects to the physicians on this study. So we're in year 3, we started recruitment and then COVID, etc. So it'll take us a little bit more time, but we are going to get there, frankly, I can't wait. The second study is a study where we created the community, another community created a series of training videos for healthcare providers. So originally it was going to be just for physicians because community members felt like physicians totally didn't hear them. Now remember, they've never seen palliative care physicians or had the pleasure of actually meeting with one. So they're talking about general physicians, but then they decided, no, this will be for all healthcare providers. And the community advisory group, which we always start with, said, you know what, why don't we speak to the pastors in the community? So we invited 17 pastors from the community, and to my great surprise, they all came, and we asked for their permission to do the study, and they were very, very supportive. We had 2 focus groups. One of the focus groups was with African-American pastors. And if you're ever going to work with the African-American community, please make sure you ask pastors for their permission. They are the leaders in the Southern African-American communities. I cannot generalize for the Northern communities, but for the Southern communities, they are the leaders. So how did we create this training? We had an advisory group. We had several meetings. And what they did is they actually saw the Vital Talk video in which a patient is being told the information about cancer recurring, which was done very beautifully. However, this community had like there were murmurs all over. And I said, what happened? What happened? And they said, how could he? How could he give this terrible news to the person when she's by herself? Where's the family? Where's the pastor? How did it? And so they realized that, you know, some of these videos, they don't meet their cultural values. So they decided they're going to make videos. Originally, they were thinking of doing another method. And the themes of the videos, we created 4 videos, were decided from the themes that came out from the focus groups. And they, once they chose the message, they brainstormed a scenario or a skit where they could highlight this. And then they developed a script for it. And then different members were either chosen to play the roles, or in the case of my student who ended up being the doctor here, voluntold to play the roles. And then the group practiced the scenario. All I did was write down what they wanted and hired a professional videographer to film these videos. They call them Communities Speak to Healthcare Providers, Conversations with African Americans at End of Life. What we found, however, is that that is insufficient, so we do not ever show those videos on their own. Dr. Barnett, who is one of my many palliative care heroes, developed a training program for the that would accompany this. And this is the training program that I invite you to participate in a few days. So I would very much like it if you would attend that. But here's the beauty of it. This is the first training program that is actually going the other way, that the community members are training the physicians and not the other way around. Sorry, we have to have the doggy on my lap because people are coming in and he gets frantic. You know, that's life from working from home. The third study that I'm not going to tell you much about, but just a minute, is that we're developing a goals of care conversation guide for physicians who are, or any clinicians caring for African Americans with a serious illness. And the reason for that is that you know how few African Americans complete advanced directives. 90%, instead of trying to push it and push it and push it, which is what we've been doing in America, what we need to do is go back to the community, ask them what are their values, how do they want the doctor to ask them about what they want for their loved ones, and that way create it. And so we're in phase 1 of the study by talking about it. It is in Birmingham, Alabama. Eventually, we will develop the program, the community will develop it, train the clinicians, implement it, and test its efficacy. I'm very excited about this study. In fact, I think we have a meeting this evening for it. So I'd like to end with 2 things. One will be the invitation to the conference, which I will show you in a second, but I really would like to ask for each of us to today make a commitment to understanding our African American patients better, make a commitment to respecting the cultural values of all our patients, and make a commitment to dismantle systemic racism. Here's the information about the summit. One of the beauties about the summit, it's virtual, so it's very easy for you to come to join it. You can keep the videos, the presentations for a month and look at it whenever it's convenient for you. But we also have this 3-hour training on 2 occasions, on a Monday and the Friday. You have to be there for the full 3 hours. And I can promise you, I don't want to give you the results of what we have found because I don't want to influence you when you come, but I can assure you that it will help you understand your African American patients significantly better, significantly. And if that's the least we can do, that's what I'm asking for. And I believe I made it in time. And so, yeah, we did.
Thank you.
I would like to hand it over now to, Dr. Ritchie to address the questions and answers.
Thank you, Dr. Elk. What a fascinating and inspiring presentation. We really appreciate your all the work that you're doing in this area. And we just encourage folks to use the Q&A function to answer or ask questions. And we have one question already, Ronit, and that is, what advice do you have about structuring the Community Advisory Board meetings? And how do you manage any differences in the group and create a positive dynamic?
Fantastic question. Thank you so much for this great question. People think, oh, well, I'll just grab a group of people from the community and put them together. No, no, no. It doesn't work like that. There's various principles. If you're really going to do it, email me and we'll set it up. But more, what I want to make sure that people are clear is that you, depending on what the focus of your study is, you make a list. Okay, we need 2 people who perhaps have lost a loved one, and 2 people from the hospital, and 2 people who are leaders, and so on. One of the keys, and that's what I love about this question, is that when you have a group of maybe African Americans and whites, you have to ensure that there is an equal number if not more African Americans, and B, that there is more an ability for the, sorry about the dogs, there's an ability that the group, the African American group, feel that they are able to talk so that they don't feel intimidated in any way at all. Everybody has a voice. And that's part of the leaders, whoever's facilitating, that's part of their skill. Excellent question, thank you.
Thank you, Ronit. The next question is, how do you ethically do a randomized trial of the processes you have described? Specifically, how do you deal with randomizing to a control group?
Excellent question too, because it would be difficult to do it if the other group was receiving something that was awful, but the other group is receiving excellent standard care that they receive in the hospital, which is the hospitalist, the medication, the nursing's care, etc. It's what's the norm, it's what's the regular standard for any patient who is admitted to a hospital, to a rural hospital. So it's standard of care, it's not less than. Ooh, that's right. I mean, I can't wait for it to come out that if this in fact does show a significant decrease in all kinds of measures, then those hospitals that don't implement it, they're in trouble, because hopefully that'll become the gold standard. But thank you for that question.
Thank you. Next question, what do you do if your community advisory panel identifies goals that are not consistent with those of the study?
Those, oh, you have to change the study. You have to change the study. That's why you talk to the patients, to the community members before you start the study. Now, in order to meet with them, you do have to have an IRB. You do have to, I mean, you have to go to the IRB, you have to get a protocol. You'll just have to change it. Now, if you're going to do, like, it's very helpful to get permission from the community first. So if you're going to come in with an idea of, we really want to make this so much better for you, in that we recognize that you have been not respected and now we want to make something that's respectful, and the community says we're not interested, well, then obviously you haven't chosen something that's appropriate for the community. It's really helpful to have these discussions with the community members before. That's why when we went to speak to the pastors, frankly, they were surprised. This is pre-America's reawakening. Oh, there is a thing as systemic racism. So at that time, it wasn't discussed. And when we came there and said, look, these are the ways you're being treated, and we want you to be treated equitably, they were kind of surprised that that there'd be people who want to do that. So obviously they gave permission for that.
Thank you, Ronit. The next question is, as a PhD student researching palliative care needs, how do you recommend asking qualitative interview questions about cultural needs in an accessible way for people from multiple cultures that may be represented in the sample?
Excellent, excellent. First of all, email me, because it's going to be taking a little bit longer than we can do here. But the way of being, there are ways you could do it to make sure that you are respectful. One way, there is a paper by Dr. Kagawa Singer, and I love the title. It's called, You Gotta Go Where He Lives. You got to go where he lives. It's so wonderful. So if you get that paper by Dr. Kagawa Singer, if you don't remember her name, don't worry, just email me. I'll give you the thing. What it does is they have A, B, C, D, E set of questions or concepts that are important that you could ask your constituents in order to sort of make sure, what do you value in this way? What's important to you in that way, etc. You could also do some reading before about some of the cultures, and definitely talk to me. Thank you for caring about that.
Thank you. And then here's a question that was actually on my mind as well, which is when you first met with African American community members, how did you describe what palliative care was, given many common misunderstandings?
Yeah, so slowly, slowly. First of all, I built some sort of relationship and trust. Secondly, I have a set of slides which has absolutely no fancy words, nothing academic. I explained the whole concept of caring. I put it in sort of African terms with African pictures of African sunsets and so on. And I very much respected the fact that I already knew how important the pastors were. I already knew how important God was. And so I was able to explain that it wasn't any of that aspect. Now, when it came to hospice, people in the community were extremely clear that they did not want their loved ones to go to hospice. Hospice was more of a concern than palliative care, because hospice meant that the loved ones had to go somewhere, or some white woman was going to come into a black family's house. And remember, the home is the one place that the African American family can do what they want. Well, more or less. I don't want to get into politics, but more or less. And so to have some white woman coming in and telling you what to do, so we had to explain that they remain in control, they remain in charge. In other words, all the concerns that the community had, and they said, don't use the word hospice. And that's a difficult thing for physicians or clinicians to do. So we talk about it as home care and immediately talk about how important it is that they remain the ones who make the decisions and that these people are not going to take over.
Thank you, Ronit. What suggestions do you have to measure implicit bias besides the implicit association test? Do you have any suggestions about that?
Very tricky question in that we have to go with what we have right now. There is a lot of pushback against implicit bias, particularly by physicians. It's not only from our work, it is from the work of several other colleagues who are working also with training physicians in various places around the country. Part of it is sort of like looking at it from an intellectual perspective. Well, this method and that method, in other words, which would be a fantastic academic analysis. However, that is the best that we have right now. The reality is, however, that people don't really want to, they don't really want to accept what it says. They don't. And that's a whole other thing. That's why the training program that Dr. Barnett developed is so fantastic, because we do the test, but we don't ask you for the results. You don't have to share anything. There's a whole lot of other things that we talk about from the videos. So you look at it from the videos and you can, I don't want to say too much. I want you to come to the training and then you can see how it's done.
Thank you. What advice do you have about creating a more diverse palliative care workforce?
Such a big question, because we need it, period. We need it. And if we want it, we can make it happen. And there are strategies to make diversity happen. It does include resources, it does include training, and it does include maybe some others who are more privileged giving up. So those are the three methods. And you can do the usual from school to academia, you could do the outreach and so on. I can tell you that I have several African Americans who are actually observing the physicians, who are observing the advisory group meetings that we have now, with the permission of the advisory group, who would like to learn to do this. And the community is very, very excited about that. I invite everybody who is especially minority faculty, students. We have a support group of African-American faculty, students, all of whom are working in health disparities, a lot in palliative care, not all in palliative care, but we build the support network, which all helps. But you have to have resources, and don't tell me you don't have them, and don't let institutions say they don't have them. They have them, they're just allocated to other things. You have to have commitment, that's my word, and then and some people may have to give up something. That's how we change systemic racism and include more minority into and think about it, if you're African American and every time you see that physicians are saying, well, why are you doing all this terrible stuff to your loved one at the end of life? Why are you doing it? And not respecting that the African American family is saying, but a miracle can happen. It's God who decides. And so if that's what you see as your image, and I know I'm exaggerating, and I know that this doesn't happen all the time, but it happens a lot. Well, I wouldn't want to go somewhere where I have to keep fighting with clinicians or have to try and change their perception. But if I see that there's respect for how I do it, and there's respect for the patient and understanding, then that can be done. And let me tell you, this whole concept of, well, you're going to do all these terrible things to your loved one, and it's costing a lot of money to the hospital. Maybe that's not said to the patient, but that's what people are thinking. If we could just say, we think that it's not going to be helpful in some way. If you feel that a miracle could happen, we'll do it. And in the end, God will decide. How difficult is it to say that? And that will also, in turn, encourage more people to come in the field because we are being respectful.
Thank you, Ronit. So here's an interesting question. I live in the Midwest, and my research focuses on end of life in the African American and Black community.
I have to talk to you. I have to talk to you.
Do you have any advice on how to get started in developing community-based participatory research to understand how advanced directives can be tailored to this community?
Yes.
I'm not done. I work for a Jewish hospice organization, and I see how culturally centered care allows for care congruent to their beliefs. I've too many times found that there's nothing like this in my community, African Americans and Blacks, and I would like to develop my program of research around this.
Fantastic. Call me, email me, relk@uabmc for medicalcollege.edu. Email me, absolutely. I'll mentor you step by step. I'm doing it for many others. Please, I'm so excited that you're going to be doing this. We train people step by step.
Thank you, Dr. Elk. Okay, so the next one thanks you for your work and your passion and your commitment. And their question is about timing and developing new partnerships right now. So they're doing virtual interviews right now to better understand the perspectives that rural Black and white caregivers have, and we recognize that the barriers that virtual data collection presents. Do you recommend continuing to forge ahead with virtual recruitment to continue to collect data during this time, or doing, for example, secondary data analysis while we wait out the pandemic? COVID presents so many conditions antithetical to true CBPR.
Absolutely. Wow, we have a fantastic group. I mean, I give talks all the time, but this group has the best questions. So yes and no, it is. And when we were stopped from doing our studies, we were beside ourselves. And one of the things about CBPR is you meet together as a group, you eat together, you pray together, and that builds such a bond. So I have 2 studies now using CBPR at the same time, and both of them we're using Zoom. And it was sort of like, oh, we're not going to have food, and how are we going to, it won't be the same. Honestly, this breaking bread is a big thing. But you know what? And at the beginning, it was a bit more stiff. It really was. Now you should see the community advisory board meetings, and it'll be the same with focus groups. everybody's talking to everybody, everybody's giving advice, you know. So the only thing that's missing is the food part. Now, when you're doing questions, I would try and do it with Zoom if possible, if the people have access to a camera, and or acknowledge that this is not the same as doing it face to face. I'm even going to be doing focus groups on Zoom. We're planning everything very carefully. Like, for example, we have one person who's our study coordinator who calls each person before and goes through to make sure that they know how to do Zoom, how they're very familiar with it. And it's helped tremendously for people to feel very comfortable and to feel a part of it. So that's also a superb question. Don't stop.
Great. Probably only have time for 2 more questions, that, which I will be asking imminently, but I want to just say that for all the questions that have been asked, we will compile them. We'll ask Dr. Elk to answer them, and we'll send them around to all the participants from today's session. So this question asked if you have any thoughts on how your findings might translate to younger age groups, young adults of African Americans who are needing palliative care.
Yeah, and what I'm hoping for, so, okay, I'm going to answer this very personally. I'm going to be 70 in a year and a half. And why is that significant? A, because I think 70-year-olds are wise. And B, because I'm not retiring till I'm 91. That gives me 22 years if you know, if my health is well and God lets me live that long and healthily. Because it takes that long to develop all of these, I hope that more and more and more postdocs or people who want to do their PhDs or their research careers will keep calling me, and then we will develop, you know, like somebody will say, I'm particularly interested in young African Americans. Perfect. Perfect. Let me mentor you and you can do your study with younger African Americans. It might come, the results might come out extremely differently. I'm still waiting for somebody up north. I had somebody up north who was going to do the study, but now that fell through because we don't know if it's the same in sort of in New York or on the Eastern Coast or even in California. So that would be fabulous. The beauty of the kind of research that I do is that these are models. I'm creating models, and you can take the model and you can literally adapt it to other groups. That's the beauty. Nothing has to be rediscovered. The answers will come from the community, but the model, you just take it and implement it. And I'm here to mentor you until I'm 91. Then I have to do other things like write books and stuff.
Thank you, Dr. Elk. We've really appreciated the energy and all the great questions from today. And as I mentioned, we will be capturing all the questions that we were unable to answer and asking for Dr. Elk's input on them, and then we'll be sending them out to the group. Naomi has put Dr. Elk's email in the chat box for your information, and I'll now turn it over to to Naomi Gallopin after thanking Dr. Elk again for a real stimulating presentation. Thank you so much, Ronit.
Thank you.
Thank you so much, Dr. Elk. As Christine mentioned, we'll ask Dr. Elk to please answer any remaining questions through email, and we'll send those around to all of you. Thank you to everyone who's joined. If you all please do go to our website, we have another webinar posted in the near future. And next month we'll have Dr. Salima Magani talking about gut qual or mixed methods data, all various ways to be part of the first ever qualitative data repository in end-of-life palliative care. Stay tuned for a very quick survey about today's webinar. And so please take a minute to fill that out. And I'd just like to thank again our panel and to all our attendees for attending. Take care, everybody.